Okay, everybody, welcome to episode 4 of Dr. D's Discussions. I'm going to set up the Facebook camera just a little bit differently. Okay, right there. Welcome to the show. It's going to be one heck of a doozy. I want to introduce to you Lebaron Agostini.
Greetings.
Woo! Welcome. Okay. Tonight's topic, we're going to be discussing male birth control, its efficacies, why it was terminated in terms of the clinical trials, and bring in another fellow PhD student, Lee here. So I'm going to let Lee take it away and actually introduce himself, get a little background knowledge, and tell the viewing audience why you're here.
All right, people. So me and Dave are PhD students at Thomas Jefferson University for cancer biology and genetics. We're here talking about male contraceptive, and principally why I'm here is because I've got a pretty good media presence on Instagram, and all of you guys should follow me at Lee the Scientist. For our IG, which plenty of posts will be coming about this talk. Mm-hmm. But for as far as scientific media is concerned, there's a lot of different viewpoints as far as how this study went. And that's not exactly what's in the media. It's not an exact reflection of what's going on in the study. And we're principally here to clear things up and give you a factual representation of what happened during the study.
Yeah, we want to take out any type of societal biases and any type of, agendas per se. When you see the clickbait titles that you've seen all week and all last week about this, it actually shot up alarm bells to me. And I actually have a particular news article that we'll reference later on in the show when we talk about the societal issues, and actually give you a little bit of why we think that male birth control is less likely to be on the market compared to female birth control, the historical implications and different things like that. But we'll do that after the science later on in the show. First, we're going to, Lee, tell me a little bit more about your background. I know that you're in the same program as I, but what's your previous history? What's your science history?
All right, for sure. So I went to Florida Atlantic University in South Florida. My major was molecular and cell bio. I have a strong emphasis in molecular genetics. Did some population genetics research on some turtles at FAU, along with some antibiotic discovery, microbiology research for the university. After that, I worked at the University of Miami doing type 1 diabetes research, studying the role of natural killer cells in type 1 diabetes.
Excellent. That's badass. All right. That's pretty cool.
Yeah, I'm all right. A little bit.
So we got a true mind here that will be able to bat ideas, and actually, he's actually done a pretty good job of the research as well in terms of getting ready for tonight's show. So let's go into the heart of the matter. The way that this actually works, it's a hormonal birth control that they were testing, and it's literally an injection, intramuscular injection. Where was the injection site you had?
So actually, this intramuscular injection is going on right at the top of the buttocks, where a lot of hormonal injections go. That tends to be like the place to put these type of injections. This trial was given every 8 weeks. Yeah, and what this injection is made up of is, excuse this pronunciation, norethistérone ethanate. God knows what that actually is pronounced as, but it's a progestin. And how that works is that it decreases or inhibits LH and FSH from the pituitary gland, resulting in a decrease in spermatogenesis, which we'll get into the biology of that later.
Interesting. You brought up the pituitary. So I thought we were talking about hormones and birth control. Like So where does the pituitary come from all of this?
Well, so spermatogenesis has two principal hormones as far as relating to it. One is testosterone. Testosterone is one of the main drivers associated with spermatogenesis, but also you need luteinizing hormone and follicle stimulating hormone to go through the 4 stages of spermatogenesis.
Cool. So we'll go into a little bit of detail about what that entails. And basically where follicle stimulating hormone and luteinizing hormone come from is the pituitary.
Right.
And that's controlled by what's called the hypothalamus. So we're going to actually take a look back here. It's actually called the hypothalamic pituitary gonadal axis. And it starts up here with the hypothalamus, which is just this little bean-shaped thing, or actually that's the pituitary, excuse me.
Right.
So it's actually a segment in the brain that controls the, blood pressure, controls your breathing, different things like that, in terms of like your acidity of your blood and different things like that. But in overall, it's kind of like the master control center for all your hormones. From what I
essentially.
And then you go down one more level to your pituitary, which makes luteinizing hormone and FSH. Primarily in this study, what we're going to look at is the effects of this norethistérone ethanate
Okay, so going forward, we're just going to... so this compound is actually in a generic female birth control known as Erin. So we're just going to refer to this as Erin going forward, okay? Just for ease on our throats and for your ears.
Yeah, because nobody wants to hear it.
Yeah, exactly.
Be muddled through this norethindrone SNA. So Erin will target basically right here. And this is where it's going to have this nice little shutdown of the production of in the testes of sperm and testosterone. So as Leah alluded to, is that follicle-stimulating hormone actually generates sperm. It generates follicle cells to produce what we'll go over later, primary spermatocytes to secondary spermatocytes to spermatids, and then spermatozoa. In conjunction, this injection was given with, I believe, a testosterone, correct?
Yes, so that's actually testosterone. Here's another doozy. Testosterone undecanate. Yes.
So we'll just refer to that as test.
Yeah.
How about that? So the test and Erin combine together to block down all the production that the testes actually make, either in terms of sperm, and not all, but to get to the point where you're sterile or not fertile.
So the WHO, the World Health Organization, actually has a standard where fertility and infertility lie for men, and this is based on sperm count per milliliter. Mm-hmm. Just to give a quick insight into the reason why they use two different hormones in this trial is because normally when you inject testosterone, your normal production of testosterone goes away. Mm-hmm. But there's been previous clinical trials associated with giving testosterone as a way to try to reduce sperm count. But long-term use of high doses of testosterone have its own slew of issues, including increased stroke and blood clotting because of red blood cell production.
Exactly.
But by using Erin, you can lower the dose of testosterone in combination with Erin, and therefore have a lower dose of testosterone with getting the same therapeutic effect.
And lower the amount of sperm.
Right. It's still producing less sperm to begin with.
So this actually reminds me of anabolic steroid use. When you hear about guys who actually, inject themselves with test this, or Trenibol or anything like along those lines, all those types of things, and they get the testicular shrinkage, and they have side effects and things like that. And I was reading through the actual study for the peer-reviewed journal article, it indicated to me a lot of those same symptoms were being seen in these types of patients.
Of course.
Would you tend to agree?
So the reality is, anybody in the world, actually, it's probably a high percentage in the U.S. that are using anabolic steroids for to gain muscle or for some athletic purpose are taking part in this trial unknowingly. Because the increased level of testosterone use reduces your natural production of testosterone and thus leads to the reduction in sperm. Mm-hmm. So you guys are actually, if you're on anabolic steroids, you have little to no worry of producing babies right now. Yep. So that may take some ease off your head. I won't even get into the other issues associated with using anabolic steroids.
We'll touch that on a different topic.
Yeah, it's a different talk.
So, hey, Uncle Joe, how are you? Hey, Marcy. So, if you guys have any questions throughout the entire show, please type them in, text them in, whatever you need to do to get a hold of us. We'll answer them as best as possible. Again, we're going to go more into oogenesis versus spermatogenesis. So, oogenesis is when you take a primordial germ cell and make a ovum out of it, or as everyone calls them, eggs. Right. So you have your sperm, you have your egg. So, Lee, the big difference between primary oocyte production to an ovum versus primary spermatocyte to spermatozoa is the quantity.
Yeah.
So a given month, one woman will produce one egg. It's usually how it goes.
Right.
That's when you see some 2 eggs, 3 eggs being formed. That's when you have fraternal twins being born, different things like that.
Rare incidents, but most of the time women are producing 1 egg per cycle.
And a polar body. And the polar body is actually what's producing progesterone to make the body switch from a menstrual cycle
to a more childbearing physiological state.
Exactly. And it actually works hand in hand with what's called human chorianogonadotropin, which actually is a pretty big, which is weird because it's a pregnancy hormone in women, but it's actually a steroid when used in men. And actually, Brian Cushing from the Houston Texans was popped hot for it after he won his rookie of the year in the NFL. So there's a little fun fact for you.
Yeah. So not surprised, but didn't know that going forward beforehand.
Yeah. Yeah. Good. So basically, what they're trying to do is, I relate it to stopping an army versus one person.
Right.
So pretend we're looking at this as like a castle, and the one defender or the one attacker that we have to get with the female is the egg, and it's only one per month. So imagine if a big castle has big walls and they have a full defense, and you only have to stop one soldier.
Yeah,
you're going to stop.
You got pretty good odds, stopping one person from invading your castle. In difference to like 50,000 invaders.
Yeah. And the whole thing about spermatogenesis, as you can see behind Lee right here, is that they produce 4 spermatozoa from one primary spermatocyte, and that's produced from making the FSH go from follicle stimulating, from the follicle cell, all the way down. But it doesn't just produce 4 spermatozoa, it produces 4 spermatozoa from every progenitor cell, but they make 1,500 every second. So imagine that castle is being inundated with 1,500 different soldiers every second. The odds are that you're going to let a few through, as compared to just going after one primary oocyte with this female birth control.
So just to touch on that, given this analogy as far as soldiers are concerned, when we're talking about sperm and there being just so many of them, and some are still going to get through, there have been a bunch of different clinical trials or methodologies trying to create an outcome for preventing male birth control. Mm-hmm. Some of these things have been for small molecule development, or like the rest of the drugs are concerned. A lot of these drugs inhibit the interaction between sperm and egg, so this is way downstream towards that process. Mm-hmm. The problem with a lot of these drugs is that they're toxic.
Yeah,
like
you said
plain and simple.
High liver toxicity.
Yeah, some of these drugs. So that's a problem. This is why this clinical trial is of relevance, because a hormonal approach is probably the best way to attack this problem.
I know we just learned in class, and I know that we just rehashed this topic, is that you'd want to go and target something more upstream rather than downstream.
Right.
And why would you want to do that?
Well, so by going inherently, things are not perfect, even this process. So by going upstream, you eliminate the risk of things not functioning. So if you're attacking something that's more upstream of a biological process, you have better chance of reducing that outcome.
Could it be likened to, say, let's go with the whole soldier analogy, maybe taking out the supply line, so to speak.
Right, of course.
Going, instead of attacking the actual army and the actual development and the training centers, and actually going, well, let's cut off the food supply.
Right.
And building from there.
Essentially, we're shooting the plane out of the sky before we can even put troops on the ground.
Yeah,
this is the type of approach that a male hormonal approach is taken for a male contraceptive, which on paper is a great idea. We'll get into some of the side effect profiles and the controversy associated with this clinical trial, but that's the idea going forward for male contraceptive.
Interesting. So we already touched on the drug name. I know that we wanted to talk about the birth control, female versus male. So let's just touch very topically on, what the efficacy rate is for female birth control, how quick it actually takes to start being able to not have children, the effective rate in terms of just how quick does female birth control versus this particular drug in general. And I'll start off with the female, and then I'll let you give the stats about the male.
Sure.
So female birth control, oral contraceptive pills will take 7 days for it to be effective. So you only have to wait 7 days before, you don't have to wear a condom, you don't have to use any type of other birth control, and have an effective rate of 99.9%. With the male birth control, I know that it's distinctly different, and that's kind of where I had my hang up with this particular drug. So if you'd like to go into a little detail.
Well, so as far as that's concerned, right? So just going into some of the aspects of this clinical study. There were 4 pregnancies, right? 320 people, over 500 people were initially enrolled in the trial. 320 of them got past the first stage, the screening stage. Then they did a suppression stage where people were actually starting to receive injections. And during the suppression stage of this clinical trial, there were 3 pregnancies. Now, I had to tell you a little bit about the suppression stage so you can kind of understand why there were 3 pregnancies. So there were 4 total pregnancies, but of those 4, 3 of them occurred here. And that's because during the suppression stage, participants were still using other forms of birth control while taking these injections. And that's because for this drug to work in men, it takes up to 24 weeks. So that means for 24 weeks, you're still producing enough sperm to potentially get your spouse or partner pregnant.
And I don't know about you, but if I'm going to be going on a birth control and there's something on the market that effectively works in 7 days as compared to 24 weeks, what's that? That's the difference between a week and 6 months.
Right.
So basically for half of a year, you're told that you have to wear condoms and everything else. So I can understand the argument that the market may not want that because in America or European countries,
there's this automatic feedback system and instant gratuity, gratification associated with everything that we want in life. And waiting 24 weeks for something to be effective is definitely a downside as far as this type of hormonal male contraceptive is concerned. But there's upsides to this too, which we'll get into later.
Yeah, of course. And I think your point when we were discussing this earlier was that 99.9% times 93%
right.
of the effective rate of this was.
So
that's
you're multiplying the risk here, right? So if I'm not taking any form of birth control and my partner is taking some form of birth control, if we're both using some form of birth control, the chances of us having a kid become like
less,
you might as well get hit by an asteroid riding a plane going to Mars. Like that is like the craziest type of scenario for you to have a kid if two people are on birth control.
Of course. So basically, instead of having one castle wall, we have two castle walls. Right. So instead of blocking 1,500 soldiers a second, we're blocking 1,500 soldiers a second and one soldier a second.
Essentially, pregnancy is the Pentagon, and you're trying to attack it with sticks. Like you're just not gonna get pregnant. Like if you're trying to get pregnant, two people, this is not gonna happen. Which is the benefit of people that are using contraceptive to begin with, right? The point is to not have kids.
Moving forward, basically, let's talk about the side effects, the stats on the efficacy, and then we can, kind of cross-compare the differences between, female birth control that's on the market now compared to the male birth control that they're testing here. And I know that, there was...
Got some quarrels here.
Yeah. So there was 4 pregnancies during this study automatically. So that already drops the efficacy rate for, I believe, 266. So 4 over 266 is roughly 97% effective. Right. Those stats are pretty good.
Which is what a lot of journals cited, but this is kind of a non-true statistic as far as the efficacy is concerned.
So we have 4 pregnancies, and tell me, what are the other hang-ups that were associated? I know that there was a couple gentlemen that, dipped down in their sperm count,
right,
and then they rebounded. So how many were those?
So again, during the suppression phase of this clinical study, nothing is perfect, and so most men received weekly injections, and then once they reached a certain amount of infertile sperm count, they were allowed to go into the efficacy phase.
What was the sperm count number? Do we have that? No worries.
I got it somewhere here. I don't know, but it's normal is 15 million per milliliter, and it's under 1 million per milliliter.
It was pretty low.
Considered infertile.
But at the same time, I know that there were 5 that rebounded during the study.
So when we say rebounded, these people are actually getting a dose of this hormonal combination. Their sperm count reduces, but during the following week or 2 weeks when they're supposed to get another dose, they have an increase in sperm count again. So that just counts against the efficacy as far as this drug concerned. Who knows what the cause of that is? Of course, I'm going to point to some type of genetic polymorphism associated with these guys and their ability to produce sperm, why this is less effective in these group of people.
And, this was a multinational type of study. So even if there was a polymorphism, say in the Belgium population, it's very highly unlikely that the same is going to be exhibited in the Indonesian.
Right.
Because there's 2 totally different separate communities, 2 completely different populations.
Yeah, inherited haplotypes are totally different here.
I think they've been separated by at least 100,000 years of breeding and different things like that. So you have to take that into consideration. But I did find the stat is that sperm concentrations less than or equal to 1 million per milliliter.
Right.
So that's a significant number in my book. If you're trying to make sure that you don't produce that many sperm, 1 million sounds like a lot.
I mean, it sounds a lot, but as far as the actual physiology of sex is concerned, as soon as ejaculation occurs, the acidity of the vagina knocks out maybe a third of that. That's why we need such a high count of sperm for women to get pregnant.
And so what's the difference between sperm and semen?
Okay, so semen is pretty much the fluid associated with ejaculation. Sperm is the actual thing. Right.
Things like that produced from the prostate, seminal fluids.
Right.
From the seminal
There's
vesicles.
some other glands associated with this as well, but sperm is actually the thing that gets you pregnant. So there are actually some congenital disorders where sperm is... So men have normal ejaculations, but they have some defect in which they cannot produce sperm.
Okay. So it's kind of like with a vasectomy. You take the sperm out of the equation,
Right.
but you still have an ejaculate, which is the prostaglandins and the seminal vesicles that you don't necessarily have. The little swimmer
Right.
guys, the little soldiers. That
Just some insight into what a vasectomy is. This is a severing or a clamping of the vas deferens, which is the
So yes,
pretty
I'm
much
going to draw a crude
the highway.
penis.
Yeah.
Okay. So you have your
Omit the word
testes.
crude penis. But yeah, so this is pretty much the highway as far as where sperm travels before ejaculation occurs.
And actually
So by
goes up
clamping
into
this
the
off-
prostate, and then up, and then goes up into the ejaculate.
Right. So you get everything else associated with the normal ejaculation, but there's no sperm there.
So you snip the pathway, so to speak.
Right.
Or tie the tubes or certain
Yeah.
things like that.
And so vasectomies are reversible. There are complications associated. If you go more than 8 years out of a vasectomy, the likelihood of it being reversed dramatically decreases.
Mhm.
The number one side effect or adverse reaction that is correlated with vasectomies is testicular pain. But it's highly effective. I
Yeah.
mean, if you cut off some pathway in my ball sacks, I'm pretty sure I would have
I
testicular pain
think
as well.
tubes being tied or severed in females is it's
Right.
a direct correlative
Yeah,
procedure.
Exactly. They're
between
almost
two
the same
sexes.
exact process as far as the physiology is concerned, but one in men and then one in women.
Yeah. So let's get back to the rebound. How many were rebound in terms of the number? So let's get
5 men?
5 men.
Yeah.
Okay, so we have 5 men, and then we also had men that didn't actually get to the threshold. As
Correct. Yeah.
Well. How many was that? Do we have that stat?
So, of the 320 participants that started, only 266 males transitioned to the efficacy phase.
Mhm.
So, just a recap of the phases we talked about. We had a screening phase with over 500. Then we got to 320. The 320 got into the suppression phase. That means that they were given doses. Then 266 got into the efficacy phase, meaning that they were allowed to have sex with their partners without any other form of birth
Mhm.
control to see if they would get pregnant or not.
So Eric did ask a good question. I believe Lee just covered that. So we had 266 in the efficacy, and we had 111 actually complete the whole study, and we had 279 go through the recovery phase. So there's a couple things that can be compounded to, I believe what the term was, compounded efficacy, or
What has the what they figured out is the true failure rate, right?
Yep.
So by subtracting the true failure rate from 100%, you actually get your true efficacy rate, which is closer to 92.5%.
So we were at 92.5% effective. And then there were other complications, not just the mood swings that everyone was talking about, not the acne. And I know that, in some of the articles that we had read, the news sources, not necessarily the journal articles and the peer-reviewed articles, had stated that, the trial was canceled because of men being wimps or wusses.
Yeah. And this is an
like
actual journal title, like not a journal, not a clinical journal, but
Mhm.
an actual news article titled "Trial is Stopped Due to Men Being Wimps,"
Yeah.
which is completely abstract compared to what
actually is the case.
Yeah, what's happened in this study.
So I know that, with the combined efficacy down to 92.5%, and the market has drugs that are 99.9% effective,
Right.
I know that's putting the burden on female partners. However, if I'm a male consumer and I think, oh, wow, this is only going to work 92% of the time, but there's a product that works nearly 100% of
Right.
the time, I'm going to ask my female partner, I don't want to put all the responsibility on her because it's a team, if you're going to be doing that, or if, like in this case, it's married men, you have to look at, would you want a car that only works 92% of the time, or would you want a car that works 99.9%
So
of the
there
time?
is the perspective where you can take the both approach, right? You're
Mhm.
on something, I'm on something, and then we will never have a kid unintended.
I like that.
In most cases, though, since birth control has been invented or enacted, rather, women have
Had to
had
shoulder
the burden.
burden.
Yeah,
Of course,
essentially. This
and
is
it's a
more of
burden.
a market. So you put something on the market, and if men are interested in taking it and it's effective, then now it gives the option that women don't have to be the sole person carrying the burden of birth control.
And I understand.
Even though you
that.
can always use condoms, by the way, which I
course.
don't understand why we don't do this. But
At the same token, I know that birth control was kind of like the key factor in the female revolution.
right.
In terms of, being able to family plan. Being able to not have children, being able to like push off the child rearing age a bit, so that females can go into the workplace and start careers. And I love the fact that that was a good consequence of birth control. And now that we're seeing a little bit of the pushback from the female community in terms of like, hey, why don't men take more of a role in this and take more of a stake in the family planning, basically.
I think realistically speaking, until we can get a male contraceptive that is just as effective as female birth control, there's not going to be a real market for this, because
I agree completely.
The reality is female birth control has opened up, along with availability to education and women's rights and everything of that, the ability to control when you have a baby has been
destiny,
exactly,
right?
has been a huge
destiny thing.
Just from a physiological perspective, if I'm a construction worker, if I'm pregnant, I'm automatically not working anymore.
Exactly.
Like, that's it. I'm carrying another human. I can't work.
Yeah.
And women have to deal with that in the workforce.
Men don't.
Yeah, men don't.
Yeah.
We don't. We have a baby.
And then we can go out and still earn money and different things like that.
Some of us have 7 or 8 babies at a time. I don't.
Let's not get into all that. That's a different societal issue. So, deadbeat dads and stuff like that. But at the same token, I really think that with men, they don't have to carry the baby. They don't have the burden. And then it's pushed more onto the women as their responsibility. So I think as soon as you get a 99.9% effective male birth control that doesn't have a 24-week start time to just get to the point where you don't have to use condoms and different things like that. And, the other thing is, the other flip side is when females are done taking birth control, they can have babies rather almost instantly. I know that, you have an increased chance of being pregnant as soon as you come off of that. I know that my fiance has told me that numerous times that, when we do decide, she does decide to get off the birth control, that we have to be careful and different things like that. But for this study, they had indicated that, there was a recovery phase.
Right. Let's get into some of these statistics, right? So, of the people that went through the efficacy phase, they entered a recovery phase. And the recovery phase was pretty much, you stop taking the shot, and we wanted to see when your sperm levels reach back to normal. The minimum time it took for any one of these participants to, and this is out of 297, I think, into the recovery phase of this clinical trial, it took 12 weeks for one person to come back.
That's just one person.
Yeah, the first person, that was the minimum, at least 12 weeks, so at least 3 months before you're able to produce a kid again. On average, though.
That could definitely be a hang-up, especially if, you have a short window, the female that you're trying to impregnate, or, the couple in general has a specific, say she has, a decreased fertility rate, she has decreased amount, ability to become pregnant by that. And, you only have certain weeks that you can have sex and different things. I know that there's family planning and different things along that nature where, you have a tight window. So if you get off this male birth control, you'd have to plan around that on top of this other aspect of getting pregnant. What was the continuation of those stats? I know it was one man for 12 weeks, and that's just one out of
right. That's the minimum. I actually don't have the average. You could look this up real quick. Have the average time it took for men to come back to normal, or what we call fertile sperm count.
So probability of recovery. So at 50% of them recovered by 30 weeks.
So this is around 6 months, a little bit more than that, plus or minus 6 to 7 months.
So it would take half of the people taking this drug 6 to 7 months to be able to have children again, and that's just only half. And I have a few other stats here that I honestly would drop this down below 90% effective because of the fertility issues afterwards, where 6 men had rebound, had to take 56 weeks for the efficacy to wear off, and then there was another. I believe one man was infertile after this study.
All right, so he's not infertile permanently. We don't know, actually. So what happens, this is a 4-year study. It started in 2011. 8 men did not recover their fertile status for spermatogenesis production within 52 weeks. Of those 8 people, 5 of them recovered within 74 weeks. So almost a year and a half.
That's a year and a half of being infertile. So would you want to take that risk as a man to know that?
Well, so let's actually talk about the risk, right? Because it's not so much a year and a half later, right? So I can't have a kid up to a year and a half after I stop this therapy. okay, I'll plan that in. But more
Okay.
importantly, there was one participant that after 4 years, he still was considered infertile by the WHO standards. Now that's a 0.3% incidence rate. So it just depends on what you're comfortable with.
Yeah.
I mean,
and I think that's a person-to-person decision. And I honestly, that should be taken into consideration when continuing the study. And I know that was one of the points of contention that, the review panel stopped the trial, stating your quote, or, your quote of a quote, recruitment should be stopped and enrolled participants should discontinue injections and be transitioned to the recovery phase because of the rate of adverse events. And some of the adverse events that we saw were acne, injection site pain, increased libido, which is actually...
So we'll get to it. Yeah, as soon as you finish, I'll talk about that.
Emotional disorder, myalgia, and then gynecomastia. And gynecomastia is, growing males.
So this is kind of an inevitable occurrence whenever you incorporate testosterone therapy into anything.
Mm-hmm.
Your body, the male body, when there's an increased level of testosterone, will turn that testosterone into estrogen
via aromatase. So it's an enzyme that will actually convert one to the other, and then that's how the body processes.
This is a secondary mechanism. So normally testosterone production is on a feedback mechanism, right? You produce a lot of testosterone, your brain goes, hey, listen, there's a lot of testosterone here, ball sacks, stop making testosterone.
Boom.
On top of that, if that still doesn't work and the body is still sensing that there's extra testosterone here, they'll go through a pathway where they'll change that extra testosterone into estrogen.
Mm-hmm. And that's why a lot of people who are, on anabolic steroids have ED.
Right.
They won't be able to, get hard. They won't be able to have sex. Their sex drive will diminish.
ED is erection, by the way.
Yeah. Erectile dysfunction.
Right.
But, I'm a little disconcerted about eight men needing over a year and, about a year, and then another 5 needing up to 74 weeks to recover. That's a bit of a scary statistic.
I think it's I don't think that statistic is enough to not put something on the market. I mean, I think early this year, I think it's all about risk assessment. Early this year, I mean, bacon got put on. So
bacon makes everything better. I don't know.
The World Health Organization puts out things that are carcinogenic every year through this assessment, and bacon is listed as causes cancer.
It's because it's a processed food that has different salts.
I mean, it's salts in the way we metabolize red meats, all these things, but the reality is the rate of increase associated with eating bacon is probably not worth it.
So I'm just saying, when they throw bacon on there, that's also populations that eat a lot of red meat, deli meats.
Right. There's a lot of factors that go into this.
And then they'll also be the types of people that will drink more, consume different things, maybe drugs, maybe it's, just maybe live an unhealthy lifestyle.
So more Western style diet, which inevitably produces a higher rate of cancer. But I just use that as an example
things like that.
To say that the risk assessment aspect of this, it's really up for you and your physician and for whatever your peace of mind is concerned with this. There are plenty of things that we do that are inherently dangerous, and there's risk associated with it.
Of course. You got to cross the street, so
right.
It's got a little bit of a risk to it.
So
I think it's for everybody to decide on their own. However, there would not be this review panel that doesn't even talk to the patients. It's not that they're in there, one-on-one.
Right.
Say I'm the physician and I'm giving, taking your history with you and your partner throughout this trial. It's not that me as a researcher went, oh, well, the guys are just being a bunch of wimps. We need to talk to somebody. We need to stop this.
Right. So review panels are looking at pure data at this point.
Mm-hmm.
You produce a spreadsheet associated with the amount of adverse reactions, the total amount, the percent of adverse reactions, and one of the World Health Organization review panels said, hey, listen, we should stop doing the efficacy phase because of the rates of adverse reactions that are occurring in this trial, which... To just segue into how the media totally fucked this over, and the reason I have a problem with this is because a lot of these media outlets
are sensational journalists.
Yeah, kind of propagated the notion that the reason why this clinical trial was stopped was because of the sheer occurrence of some of these side effects. Let me quote some of these things from an article. Minestrone 24 FE, right, is a oral contraceptive for women, headaches, nausea, menstrual cramps, yeast infections, breast tenderness, acne, mood swings, and weight gain. NuvaRing is a intravaginal hormonal contraceptive, headaches, mood changes, nausea, vomiting, weight gain, acne, decreased libido. So then it goes on to list a bunch of other female contraceptives.
So is female contraceptives, birth control, only used for female birth
No,
control?
not at all. It's used for a multitude of things, including decreasing the severity of a period to begin with. Also, regulating cycles. Some form of contraceptive for women decrease the occurrence and stop them from having a period altogether, which for some women, especially if they have severe menstrual cycles, is a huge upswing.
To people who have different types of jobs. If you can't, necessarily, let's say you're out in the field, you're working, let's say you're on a pipeline or an oil rig, that time of the month is going to be a little bit of a detriment towards, working out in the field. Maybe you want to reduce the amount of periods that you have and the longevity and the duration and like the severity of it, just so that it's a little bit more of a convenience factor. And I'm not saying that that's primarily the only reason why women take it, but that could also be another idea. With the male birth control, we didn't see the secondary types of
Of course, they're not assessing these type of things during the clinical trial. This phase 2 trial is just to see whether or not this treatment is effective. And so the reason why I started to quote this article is because they're trying to say, well, women have these side effects and men have these side effects, and they stop the clinical trial. This is not about the side effects. It's more about the rate of side effects. In women, with something called the Mirena intrauterine device, the rate of acne is 6.8%. Minestrone 24 FE has a 70% reduction rate in acne in women. 50% of the men in this clinical trial experience acne.
45.9% experience an increase in acne that didn't have acne before. So that's also, what I'm getting at, where, women will take birth control to reduce the acne. So they have really bad acne. That could be a type of strategy that her and her doctor could discuss to reduce it. However, on the flip side of it, no man is going to go in and be like, hey, doc, I want to get more acne. Load me up with a bunch of drugs. It's kind of like... I love this new acne I'm getting. I want more of it. Can I get this shot, please? No, that never happens. Or, and then the other thing was 16% myalgia. Like, that's pain. That's muscle pain that you cannot do anything necessarily for. If you've ever heard of fibromyalgia, that's kind of like...
it's just nerve pain. That's what fibromyalgia is, but that's a problem within itself.
So we have a question about the cost. The cost is going to be eaten by the pharmaceutical companies that are actually pushing the drug trials.
The cost of the trial of the injections.
The injections. So we're not going to be necessarily given a cost for the injections because it's not on market yet. So it hasn't gotten even to the
That information is completely unavailable at this point.
So, the company that's pushing this and actually pushing the study and actually hosting the study won't have that available until they actually bring a drug to market. And that requires, FDA approval, the European, I think it's the FDA equivalent. I don't know.
I'm not sure what.
But they need to approve it for their markets. Japan needs to approve it for their marketplaces and different things along that nature. So that's pretty much why we won't have the cost of the drug just as of yet.
I can say though, one of the adverse reactions that I thought shouldn't even be called an adverse reaction is increased libido. 38.1% of participants had increased libido.
All I'm saying is not every guy is good looking like you, my friend.
I don't know. I can't think of an instance where increased libido would be a bad thing, unless I'm a rapist. Then that could be detrimental.
Jesus
if you're a rapist in this trial, I'm sure you're convicted 75 more crimes than normal. But for most people, that's probably an okay side effect.
Yeah, I don't think that was necessarily the one that, was the hang-up. I don't like the other ones. Injection site pain, a lot of people give that a little less credence. But when you're discussing the injection of a hormone, it's going to be a thicker hormone. That injection
This secretion is inherently more thick than any other type of flu vaccine, for example, is a great... These things aren't particularly viscous. And this is also an intramuscular shot in the buttocks.
Yeah, so it's going to sit in there. And then I know that you brought up the point that in the populations that they're testing this in, Belgians, Indonesians, they tend to be smaller than your average Americans who have more mass on them, so that their buttocks might not be able to take the injection as easily.
I want to get into a side effect that a lot of media outlets decided to focus their attention on, and it's the emotional disorders. 16.9%. So let's just round it to 17%. Of trial participants had emotional disorders. I want to point out two key facts about this. One, 62 of 65 of the emotional disorders that were reported occurred at one treatment center. So this is a multi-treatment center study in different countries.
Yes.
So in the treatment center where 62 of 65 emotional disorders were reported, that was in Indonesia.
Yes.
I'm not sure what the social like societal aspect of?
I can talk a little bit about that. I know Indonesia is a little bit more of a conservative country. They have a little bit more of a more religious background, so they have what you would consider, conservative male-female roles, gender roles. So, a female would be told that, you need to take this, and you need to just suck it up for the man. So I can see why the media sources did get a little up in arms in terms of, pushing that mantra that, the men in this study were just wimps and different things like that. But
and a lot of studies didn't. A lot of
difference. Like Indonesian men, they're not going to want to deal with this pain or deal with that different thing. Like in Belgium, I know that 80% of them wanted to continue on doing this trial and actually like the not necessarily the effects, but they liked the outcome that they were getting in terms of not having kids. They were able to be with their wives and not get pregnant. So I think there's a distinct difference culturally why this trial was actually stopped, and I think that has to be pushed to the forefront rather than just saying, men in this trial were wimps, they were wimps, and that was the end-all be-all. And that's not necessarily the case, given the fact that we looked at 4 pregnancies, 5 rebound, we had, 8 men that had to go past the 56 weeks. We had 5 that went up to all the way up to 74. There was a guy that's still up until today not able to be, fertile in terms of the
as far as the standards are concerned,
yes. The clinical standard. So, all these things taken together indicate to me that maybe this wasn't the best drug, and that this trial is just maybe a stepping stone to better drugs. And it looks like they have a really good strategy in attacking the upstream effect, the upstream making of the spermatocytes in the spermatozoa, and using this as more of a means to do a different drug, maybe tweak it a little bit.
Well, from a mechanism of action perspective, as far as this clinical trial is concerned, I love the mechanism. I think the approach is great. Even in for those people that aren't frequent to reading clinical journals, that's why we're here. So we can read the clinical journals and tell you what's going on.
Kind of relay the information in a simpler type of way.
Right.
Let's just. Does anybody have any questions out there? Nate, Rose, do you guys have any questions in particular? I know you're behind the scenes today. No. Other than that, Lee, do you have any type of more insights into this?
I do want to say 2 issues that I had with the study within itself. One is they only tried 1 dose associated with this study, which in the discussion aspect of the journal, they said that there might be a way to reduce some of the adverse events by playing with the ratios associated with these 2 drugs and the frequency, because this was done every 8 weeks. So
maybe if you did it maybe every 2 or 4 weeks.
Or 12 weeks or whatever. Longer, you can try to limit some of the adverse reactions here. But that wasn't done in the study, so we only have 1 type of model to guess off of.
Yeah?
I did have a question.
It's from our audience, actually.
Yeah, we're in the live studio audience.
Right.
So you know how Viagra was discovered because it was actually supposed to help for the lungs? So do you think that this could potentially be a type of medication that could also be used to help with ED? But in a sense, the fact that it was helping
it actually caused some ED. So
ED and libido are libido is considered like the urge to have sex. We had it, so more people in the study were like, I would like to have sex rather than I did before.
But there was also an increase in the amount of men that were experiencing erectile dysfunction. And actually, a few of them pulled out of the study because of that. And they actually couldn't, maintain an erection, and they couldn't act on their increased libido. So that could be, those 2 things hand in hand put together.
Even though these percentages of decreased libido, increase in erectile dysfunction were small, there is still something to consider in regards to reviewing this.
And you also have to look at it like this: what man, maybe a couple other men in this study did have ED, but were a little bit more of ashamed to bring that forward. That there's a shame in that type of thinking.
Right.
You can't get it up, you're not man enough.
Right.
So there's also that type of thinking where, there might be an underreported type of aspect to the adverse effects.
Even idealistically, we want people to be as transparent as possible in these evaluations that we ask them, but that's never the case.
Exactly.
But one of the things before we transition to a different topic is that there's no placebo group in this study.
And for obvious reasons, you can't really have a placebo group with this because you can't just go and tell people, hey, we're going to maybe give you a drug that will keep you from having
But I want you guys to have sex at least twice a week, which is part of the stipulation for the clinical trial.
And then you only give them like a sugar pill or a saline injection of some sort. And then all of a sudden you have a control group of 50 people that they're all pregnant. So
I will say this though, when evaluating something like, so of course, right, like 50% of the people got acne. That's drug related.
Yeah.
But the 17% of people that talked about emotional disorder, we don't know what the placebo addition is.
Yeah.
In the placebo group, that could have been 12% or 15%. So is 15% of emotional distress or emotional disorder versus 16.9%? That's not drug related.
Mm-hmm.
That's expectation.
Yeah.
So
that's just somebody who they could just also be emotionally disturbed coming into it. They could have depression. They could have some other clinical types of symptoms. I know one person in the study had actually committed suicide, but it was basically because he had stressors outside of his life. I think it was his family had said they was school related and academically related. So they didn't even put that into the adverse effects or into the emotional disorders that were actually calculated in terms of percentages.
So in clinical trials, they have to report everything. But the WHO, the panel that reviewed this thing, actually followed up on that. And you're actually correct. It was what they reported was that this person's suicide attempt was academically related as far as how that person dealt with the pressures or whatever. So yeah, that can't be really count against the trial. It is an interesting thing, but when you're screening 300 or 400 people at a time, you can expect any occurrence to happen in clinical trials.
So are there any other? Why not make male birth control compared to female? We touched on that. We touched on some of the headlines in terms of being clickbait. I think that's pretty much. I think that pretty much covers the entire topic. So I know that we're at the 46-minute mark, so I think we'll wrap it up. Lee, thank you for joining me this week. I really appreciate it. We'll see you in the future as well. Nate will be back next week, hopefully. Maybe we'll do a 3-person panel next week if Lee's available. That would be great.
We're not in a lab,
So next week we're going to do a little bit of the pipeline, North Dakota Access Pipeline. We're going to discuss the Treaty of 1851, the Fort Laramie Treaty, and discuss what the repercussions are of the modern day. We'll talk about the governor of North Dakota having ties to ExxonMobil, and then we'll also update about the election. We'll discuss a little bit about what happens this week on Tuesday. I know I had a comment from one of the viewers that we didn't touch on gun control and a lot of climate change. I think we're pretty sure about who's for what and different things like that. I know I'll talk really briefly. Trump is, a pro-gun guy. He's an anti-climate change guy. He thinks China was behind the hoax that is climate change. And also Hillary Clinton is pro-science, pro-climate change, but she's also pro-fracking, so that's kind of against her. And I don't think she's 100% gun advocate, but she's never going to take anybody's guns away, and that's the cold, honest truth. We'll also try to get a science topic for next week, and we'll touch on it briefly. Moving forward, we're going to be starting up a website with blogs. I know that Lee the scientist, get down that IG.
So, yeah, just to touch on that. So, me and Dave are going to be bringing some new age, more or less clickbait worthy scientific content on a blog, and hopefully some cool videos like this one.
And also Nate will be doing marketing as well if he has the wherewithal and the time. I know that he's a busy man. So we'll be throwing a bunch of different things at you guys. So keep up with us. Dr. Dave Discussions on IG, Dr. Dave Discussions on Facebook, Lee the Scientist on IG, and YouTube, Dr. Dave Discussions. Please check out our channel.
Yes,
please
like subscribe.
Us. Subscribe. Give us some shares.
Also,
love the shares.
Post comments. We'd love to answer your comments in extended blog posts.
Of course.
Dedicating some serious conversations towards the questions that you have that we can't answer in 45 minutes, either on IG, followed up on our blog post, and on Dave's Facebook page.
Perfect. All right. Lee, thank you very much. And thank you all for catching us this weekend. Hopefully you guys will be watching The Walking Dead, because I know I will be. All right, guys. Check you later.